Obviously, every institution has its own pathways, its own formulary, and although many of these therapies we prescribe now require, pre-authorization and, especially pharmacies delivering the therapy. I think the difference between community and academic centers is that maybe a medical oncologist in community who does not have a high volume of patients with renal cell carcinoma and a patient may have adverse events with a particular therapy, they may have a low threshold to switch therapy to another agent. And I think there have been studies showing that, first-line therapy, for example, with sunitinib or pazopanib, that time on therapy at an academic center with these agents is longer than the typical time on therapy with these agents in the community. And I think, local oncologists have a tendency to maybe, if a patient is having adverse events, rather than manage with, as we mentioned, some of the strategies to manage adverse events with interruption, dose reduction, aggressive supportive care, they may, because we have options, we have choices, they may go to a second line before they get the maximum mileage out of therapy. My experience is I like to maximize time on therapy with each particular line of therapy, to maximize, to give that patient the potential for the longest progression-free and improve survival. And I think this is my message to medical oncologists in the community who don't see as many patients with renal cell carcinoma, is to be patient, manage the adverse events. The adverse events can be managed. And we have algorithms, and we have trained our advanced practice providers to call the patient, manage the patients, and be in close contact with the patient and families to manage these adverse events. So regarding how many, and I have patients at MD Anderson who are receiving 9th line of therapy. I think those patients who end up receiving multiple lines of therapies are those patients who their disease, the biology of their renal cell carcinoma is more indolent, and they get a chance to go from one line to another. Unfortunately, there are patients, still many patients, unfortunately, that we lose within a year or even shorter time, because their disease is so aggressive, relentless, and they do not respond to therapy. So I think biology here plays a role as to the duration of therapy and how many lines a patient sees. And of course, if you compare the US versus other countries like Europe, for example, we have the luxury of having all those options available to our patients, whereas in Europe, for example, they cannot prescribe any agent except the way the EMA, the European Medicine Agency, approved it in that line of therapy. And that's why the American patients have the opportunity to receive multiple lines of therapy here, because we have these agents on the market. But I think it's important also to look at NCCN guidelines. In their guidelines, they can help guide medical oncologists in community to choose how to choose their salvage agents for therapy.